If you are over 45, your annual pap smear came back normal, yet intimacy hurts, your doctor missed something critical. A pap smear only screens for cervical cancer cells, completely ignoring the progressive tissue atrophy silently starving your pelvis of estrogen. You might feel a constant sandpaper sensation during intercourse, or suffer from phantom urinary tract infections that return after antibiotics. Mainstream medicine often dismisses these symptoms as normal aging, leaving you to suffer in silence with useless over-the-counter lubricants. The painful truth is that your vaginal and urethral tissues are literally starving because of a severe lack of local estrogen. This is not a psychological issue, nor is it a personal failure that you must quietly accept as you grow older. Today, we are stripping away the cultural shame to address this progressive medical condition with precise scientific hormone protocols. Let us discuss exactly why your pelvic tissues are changing and how you can reclaim your physical comfort immediately. Many women assume that starting systemic hormone replacement therapy patches or oral pills will automatically resolve all pelvic dryness. However, clinical data shows that systemic treatments only fully resolve local genitourinary symptoms in about half of all patients. Your pelvic organs sit at the very end of the systemic circulatory line, receiving minimal hormones from standard patches. If your systemic estrogen dose is kept low, your vaginal and bladder tissues remain severely starved of vital hormones. Increasing your systemic dosage is not the answer, as it can trigger unwanted side effects throughout your entire body. Instead, you require a targeted, localized application of hormones directly to the tissues that are experiencing severe thinning. We must treat this as a localized structural tissue disease, requiring a highly specific clinical protocol for lasting relief. Let us dive into the precise science of localized therapy that your primary care physician likely never explained. I am Dr. Lisa Sheld, a board-certified gynecologist-endocrinologist and a North American Menopause Society certified practitioner. For over 17 years, I have dedicated my clinical practice exclusively to managing the complex transition of midlife women. As the director of a specialized menopause clinic, I have personally treated more than 10,000 patients facing these challenges. My treatment methodologies are strictly anchored in the latest clinical guidelines from NAMS, KEEPS, and the ELITE trials. I work closely with leading global experts like Dr. Mary Claire Haver and Dr. Louise Newson to advance care. Our goal is to replace outdated medical dogmas with evidence-based endocrinology that restores your physical and sexual vitality. You deserve access to the exact same medical protocols utilized by elite menopause specialists worldwide to treat tissue atrophy. Together, we will navigate the complex biological shifts happening inside your body with complete transparency and clinical accuracy. In my clinic, we speak about anatomical realities without using awkward, evasive euphemisms like down there or intimate dryness. We will openly discuss the vulva, vagina, urethra, clitoris, and the physical pain experienced during sexual intercourse. Stripping away the societal shame allows us to examine the biological mechanisms driving your painful symptoms with absolute clarity. Your pelvic health is just as important as your cardiovascular health, requiring the same level of medical attention. When we look at the pelvis, we are looking at a highly complex, hormone-dependent ecosystem that requires proper maintenance. My clinical experience has proven that restoring this ecosystem requires precise, targeted hormone delivery rather than general lifestyle advice. Today, you will receive a masterclass in pelvic endocrinology designed to help you advocate for your own healthcare. Let us uncover the biological truth about why your body is reacting this way to declining estrogen levels. The mainstream medical system routinely fails midlife women by treating progressive vaginal thinning as an embarrassing, minor cosmetic issue. Many patients tell me their doctors suggested drinking a glass of wine to relax before attempting painful intercourse. Others are repeatedly prescribed antidepressants for somatic pain or given endless rounds of antibiotics for phantom urinary tract infections. These unnecessary antibiotics destroy your gut microbiome while completely failing to address the underlying cause of your burning sensations. When your pelvic tissues are thinned and raw, even simple friction can feel like rubbing sand into an open wound. Yet, your physician might perform a basic pelvic exam and declare that everything looks completely healthy for your age. This medical gaslighting leaves women feeling broken, isolated, and convinced that their sexual lives are permanently over. The reality is that your tissues are undergoing structural changes that require medical intervention, not psychological counseling or relaxation. Consider my patient Sarah, a 49-year-old corporate attorney from Chicago who came to my clinic in absolute despair. She had visited 3 different primary care doctors, complaining of intense burning during sex and constant urinary urgency. Each time, her routine urine cultures came back completely negative, yet she was repeatedly prescribed ciprofloxacin and macrobid. Her gynecologist performed a quick pelvic exam and told her that her tissues looked normal for her age. She was handed a tube of over-the-counter water-based lubricant and told that she simply needed to reduce her stress. The commercial lubricant only caused intense burning because her vaginal epithelium was already severely thinned, raw, and highly inflamed. Sarah felt completely abandoned by her doctors, believing her marriage was failing and her body was permanently broken down. Her story is incredibly common, representing a widespread failure of basic gynecological care that we must actively correct. Let us analyze the exact biological cascade that occurs within your pelvis when your systemic estrogen levels begin dropping. The vagina and urinary tract actually contain the highest concentration of sensitive estrogen receptors in the entire female body. When estrogen levels decline, your body stops producing adequate collagen, causing the vaginal walls to lose their natural elasticity. The epithelial tissue thins dramatically, making it highly susceptible to painful microtears during any form of physical intimacy. Furthermore, a lack of estrogen causes a severe drop in vaginal glycogen, which is the primary food source. Without glycogen, beneficial lactobacilli bacteria die off, causing your vaginal pH to shift from acidic to highly alkaline. This alkaline environment allows aggressive uropathogens, like E. coli, to colonize the area, causing recurrent, painful urinary tract infections. Your burning, urgency, and painful intercourse are the direct physical consequences of this progressive, untreated cellular starvation process. Fortunately, you do not have to live with this painful, progressive deterioration of your pelvic and urinary health. Today, I am sharing the exact 3-step Genitourinary Syndrome of Menopause resolution protocol used in my private clinic. This comprehensive protocol combines low-dose local vaginal estrogens, targeted DHEA therapy, and non-hormonal, high-molecular weight hyaluronic acid moisturizers. I will outline the precise starting dosages, exact application techniques, and the critical safety data you need to know. You will learn how to safely restore your tissue thickness, rebuild your collagen, and normalize your vaginal pH levels. We will also address how breast cancer survivors can safely navigate these localized treatments in coordination with their oncologists. This protocol will provide you with the exact clinical words to say to your doctor to secure your prescription. Prepare to take detailed notes as we transition directly into the highly specific, science-backed medical recipes for your recovery. Our first clinical protocol for treating severe pelvic atrophy utilizes localized vaginal estradiol cream at a 0.01% concentration. During the initial loading phase, you will insert 0.5 grams of estradiol cream deep vaginally every night for 14 consecutive days. You must also apply a tiny, pea-sized dab of the excess cream externally to your vulva, clitoris, and urethral opening. This targeted external application directly addresses clitoral sensitivity, vestibular burning, and the constant urge to urinate after physical intimacy. After completing the 2-week loading phase, you will transition to a maintenance dose of 0.5 grams twice weekly. This localized estrogen works by binding directly to estrogen receptors in your pelvic tissues, stimulating rapid local collagen production. It thickens the thinned epithelial layers, restores natural tissue elasticity, and successfully reverses the painful sandpaper sensation during intercourse. Most patients experience a significant reduction in external burning and a noticeable increase in natural moisture within 4 weeks. If you find creams messy or inconvenient, the second highly effective option is the localized vaginal estradiol tablet. Brand names like Vagifem or Uvifem contain a precise 10 microgram dose of estradiol, which is inserted using a slim applicator. The loading phase requires inserting 1 tablet vaginally at bedtime every single night for 14 consecutive days. For long-term maintenance, you will insert 1 tablet vaginally twice weekly, spaced out evenly, such as every Monday and Thursday. This microdose is exceptionally safe because the systemic absorption into your bloodstream is clinically proven to be completely negligible. Using this tablet for an entire year delivers a total systemic dose equivalent to taking just one single oral hormone pill. Your circulating blood levels of estradiol will remain safely within the normal, healthy postmenopausal range of under 20 picograms. This makes local tablets an outstanding option for women seeking highly effective results with maximum safety and minimal mess. For women who prefer non-estrogen local precursors, intravaginal prasterone, also known as DHEA, is an exceptional alternative. Brand name Intrarosa provides a 6.5 milligram insert that you place vaginally every night at bedtime. Your local cells absorb this DHEA and convert it into both estrogen and testosterone directly inside the tissue walls. This dual conversion is highly effective for rebuilding thinned pelvic muscle fibers and significantly reducing deep vestibular pain. To maximize your results, combine your hormonal therapy with a high molecular weight hyaluronic acid vaginal gel on non-hormonal nights. This non-hormonal gel acts as a powerful humectant, drawing water deep into the thinned intracellular spaces of your tissues. This combined approach restores your natural acidic pH of 3.5 to 4.5, bringing back healthy lactobacilli bacteria. Within 8 to 12 weeks, your vaginal ecosystem is fully restored, virtually eliminating recurrent urinary tract infections. Before initiating any localized hormone therapy, we must address critical patient safety protocols and absolute medical contraindications. If you are experiencing any unexplained or undiagnosed vaginal bleeding, you must pause and seek immediate medical evaluation. Your doctor must perform a transvaginal ultrasound or endometrial biopsy to rule out endometrial hyperplasia before starting hormones. For survivors of estrogen receptor-positive breast cancer, local vaginal estrogen is still a highly viable, clinically supported option. Both NAMS and ACOG confirm that low-dose local estrogen can be safely used if non-hormonal treatments fail. However, you must co-manage this therapy with your oncologist to ensure complete safety and personal peace of mind. Be aware that some generic vaginal creams contain propylene glycol, which can cause temporary local burning upon initial application. If this occurs, simply switch to the vaginal tablet or the E-string silicone ring to avoid localized tissue irritation. Understanding the physiological timeline of your recovery is essential for maintaining realistic expectations during your healing journey. During the first 2 weeks of treatment, you will notice a rapid reduction in external burning and itching. By weeks 4 to 6, your vaginal tissues will regain significant moisture, elasticity, and comfort during physical intimacy. By week 12, your vaginal pH will normalize, lactobacilli will return, and recurrent urinary tract infections will cease. You must understand that genitourinary syndrome of menopause is a chronic, progressive condition that does not resolve spontaneously. Unlike hot flashes, which may eventually subside, the structural tissue changes of pelvic atrophy require ongoing medical management. If you discontinue your localized hormone therapy, your symptoms and tissue thinning will inevitably return within 6 weeks. Consistency is the key to maintaining a healthy, resilient pelvic ecosystem that supports your comfort and sexual vitality. Let us establish a clear, memorable script you can take directly to your next primary care appointment. If you are 48, sex feels like sandpaper, and you are constantly treating phantom urinary tract infections, listen closely. Your pain is not in your head, and your normal pap smear did not catch this progressive condition. This is genitourinary syndrome of menopause, a treatable structural disease caused by localized pelvic estrogen starvation. I routinely prescribe my patients low-dose vaginal estradiol tablets to reverse the cellular thinning at the biological root. You use 10 micrograms daily for 2 weeks, and then transition to a maintenance dose of twice weekly. This microdose does not enter your bloodstream in any meaningful amount, ensuring an exceptional clinical safety profile. It simply rebuilds the collagen, elasticity, and acidic pH of your vaginal walls, stopping the pain immediately. Your complete recovery strategy requires a comprehensive hormone panel to evaluate your systemic and localized endocrine health. This diagnostic panel must measure your estradiol, follicle-stimulating hormone, luteinizing hormone, free and total testosterone, and thyroid markers. We also evaluate sex hormone-binding globulin, DHEA sulfate, and free thyroid hormones to establish your precise biological baseline. Combining these diagnostic results with localized vaginal estrogen and systemic micronized progesterone forms the gold standard treatment protocol. This dual approach safely addresses both your vasomotor symptoms and the progressive structural thinning of your pelvic tissues. By targeting the specific receptors in your bladder, urethra, and vagina, we systematically restore your entire pelvic health. Reclaiming your physical comfort is not a cosmetic luxury. It is a fundamental aspect of your overall well-being. I see patients who for years said, "I am no longer myself," return to exactly who they were after 3 months on the correct protocol. This is not magic, it is simply endocrinology. If this clinical breakdown brought you clarity, please subscribe to our channel to join our growing midlife community. Please share your current age, your top 3 menopause symptoms, and whether you have ever had a hormone panel. Your comments help us design highly targeted, science-backed educational videos to support your personal health journey. Do not forget to download our free menopause symptom tracker and hormone test checklist PDF linked in the description below. This comprehensive guide will help you document your symptoms and prepare for your next clinical doctor appointment. Use our directory to find a North American Menopause Society certified practitioner in your local geographic area. Having a certified specialist on your healthcare team ensures you receive the most advanced, evidence-based treatments available. In our next masterclass video, we will explore the clinical role of testosterone therapy for restoring female energy and libido.